So good afternoon, everybody. My name is Kathy Pabst. I'm the Executive Director of the Missouri Academy of Family Physicians, and we are hosting a series of a day in the life of a family physician for our Missouri medical students. We hope you consider family medicine as you start looking at residency programs. And part of what we're doing with this series is to show you how you can be a subspecialist within family medicine. And today's session is going to focus on emergency medicine. And Dr. Charlie Rasmussen has been on the board and off the board a couple of times, but a big supporter of the Academy. And he's going to share some of his experiences and his journey to where he is today. I do want to remind everybody, if you can check the name on your account. If it is not your name, if you can go in and rename yourself, that way we'll know who's exactly on this meeting. So with that, I'm going to turn it over to Dr. Rasmussen, and we can hear his story.
Kathy, thanks for having me, and thanks for the MAFP for doing this series. I think it's great, and I'm excited to talk today about family medicine and also kind of how you can do so many different things in family medicine. And I think that is one of the beauties of family medicine, especially if you were to choose to do it in more of a rural area like what I have. So I was just going to kind of go through my story and how things, worked along the line and kind of where I'm at now, and then maybe go over a couple of cases from the ER, and then just kind of open it up for whatever questions that I can help you guys answer. So I went to college down in Springfield. It was Southwest Missouri State at the time, and for the longest time I thought I was gonna do dentistry. I was pre-dental, I was moving, and then about junior year or so, I shadowed a dentist over Christmas break, and I said, oh wow, just all you do is teeth just all the time. I need more variety, in my, career choice. So kind of put the brakes on that. And while I was an undergrad, I was working at Cox South, and my very first job there was radiology transporter. So that is I don't know if you guys have heard of it, it's a very glamorous job. People try to get it all the time, where you take patients from their room in the wheelchair or the gurney down to x-ray and back. And so that was kind of how I first got into the world of hospital medicine, and then quickly graduated phlebotomy. And while I was down there, I would frequently go into the emergency department, and I was talking with one of the doctors, and they were kind of asking me what my story was. And I kind of told them about how dentistry wasn't going to be for me. And they were like, we've got all the courses and everything else. Why don't you think about medicine? And I said, great idea. And so I put in my application, but by now I'm a senior in college. And so it looked like I was going to have about a year's lag time there. And so I moved up to Kansas City and took a job at the health department in Kansas City as an epidemiologist. And so part of that was you compiled statistics and did different things for the Centers for Disease Control. And we investigated hepatitis A outbreaks, and we did directly observed therapy for patients with tuberculosis. And it was also very interesting, but a lot of it was office-based, sitting behind a computer, and I knew that just, wasn't, for me. And so I applied and got into medical school at Kansas City, at the osteopathic school there in Kansas City. And throughout my rotations there, starting third year, one of my first rotations was family medicine, and I loved it. And then I went on to pediatrics, and I loved pediatrics, and went on and delivered babies, and that was great too. And so, I really liked everything, and that's why I was really kind of leaning towards family medicine. But when I did my emergency medicine rotation, boy, I was really interested in that. And, so one of my emergency medicine rotations, I went out to Denver Health, and and rotated at the downtown like county hospital. And man, it was intense, and it was, a lot of what I wanted. But at the same time, I said, gosh, I really miss that continuity of care. I'd really like to take care of, patients in the hospital and deliver. And so I did a rural rotation up in Montana where I had some great, mentors, and there was some faculty there in Billings, Montana, and they said, hey, you can, do this all. It's, it takes a lot of work, and you're going to be held to the same standard in the emergency department as the emergency trained, physicians. And so you're going to have to really, kind of work extra hard and do some things that, maybe your colleagues that choose to do, outpatient only, might not have to do. But I said, hey, I'm up for it. So I looked for a real, a family medicine residency that would prepare you for rural, health and, obstetrics and emergency medicine and all things that you would need to take care of community. And so I landed in Springfield, Missouri at Cox and got some great training. And from there, I went out to Houston, Missouri. So I graduated residency in about 2007. And my first practice was in a little town called Houston, Missouri, which is kind of just south of Rolla, about 45 minutes if you know your mid central Missouri geography. And it was in Houston, Missouri at the time. It was, let's see, 4 family physicians and 2 general surgeons. And part of what I did in residency was I actually did some moonlighting shifts out in Houston. And so in addition to my inpatient and obstetric practice out in Houston, I'd also pick up emergency room shifts like on the weekends or, when I had, some spare time just to, kind of continue to keep those skills and build those skills. And I practiced out there, and it was a very rewarding practice, kind of full scope family medicine. And then about 2013, my wife and I had recently had a daughter, and we wanted to kind of move a little closer to family, which took us to Branson, Missouri, which is where I still am. I own and operate a private clinic called Table Rock Family Medicine, where I do obstetrics and inpatient and family medicine. But I also have joined as a partner a group called 360 Medicine, which is a group of primarily emergency medicine boarded physicians. And we cover 3 main hospitals. We cover Branson, Harrison, Arkansas, and Lebanon, Missouri. And so they're pretty moderate volume emergency departments. About, Harrison probably has about 25,000 annual visits. Branson closer to 40,000, and then Lebanon somewhere in the neighborhood of 22 to 24,000. We also will end up covering a lot of other rural hospitals like Cassville and Aurora. There's a little small shop down in Clinton, Arkansas, where we work 24-hour shifts. And so I'll occasionally go down there. And the other thing that I do a variety of different things. I work with Docs Who Care, which is a great organization based out of Kansas City, founded by a family physician who help cover rural emergency rooms in Colorado, Kansas, Iowa, Nebraska, and Missouri. And so occasionally I'll work for them, like up in Appleton City, which is a little 3-bed emergency room, and you might only see maybe 8 to 10 patients in a 24-hour period, whereas when I work at some of the higher volume shops, you'll see 20 or 25 patients sometimes in a given shift, depending on how long you're you're working there. So I've kind of split time between my private practice and being a full partner with 360 Emergency Group. And again, that's the nice thing about family medicine is I've had some colleagues that have kind of broken off and chose to do emergency medicine only, and then other colleagues like myself that choose to do a little bit of both. And I really think the variety is so nice. And maybe, maybe someday when I get tired of getting out of bed at 3 o'clock in the morning to go catch a baby, well, I'll say, well, maybe the emergency room where you don't have call and you don't have the pager, might be a better, fit for me. But I think the emergency medicine is just a real natural, kind of offshoot or part of, family medicine training, because there's so much that we get in our family medicine training that's just, so applicable to the ER. The other thing I love about working in the ER is I'm, well versed in obstetrics. I probably delivered, over 1,000 babies by now, I think, in my career. And so most emergency physicians, if they're boarded in emergency medicine, if you mention the word pregnancy, they get real sweaty and shaky. And, but I love to see, pregnant patients in the ER. And so again, just all these skills that we develop, through our training, is, makes it perfect, to be in the emergency department. And there'll never be enough emergency boarded physicians to cover all of the emergency departments in the United States. Right now, I think the latest statistic was they've got about 75% emergency physicians covering ERs in the United States, and about 25% are made up of family medicine or sometimes internal medicine or even pediatrics. And so, like I say, especially in the rural area, it's just such a natural, thing to do. And whether you choose to, kind of do it like I did it, or, if you're out there practicing in a rural, area, you're probably going to get pulled in, from time to time to, something that needs your skills as a family physician with, critical care and emergency type of, skills. So I'll never forget my very first year out in Houston, Missouri. I was working in the clinic. It was sometime in December, and it was one of those times in Missouri where we get a lot of rain, and then all of a sudden the temperature drops and the roads get real slick and things get wild. And so I was just wrapping up clinic, and the emergency doc that was covering the emergency room there in Houston, who was also a family trained physician, Dr. Jeff Kerr, who's again also just a great, role model as a family physician who's chose to make emergency medicine his, kind of full-time specialty, called me up and said, "Hey, Charlie, can you come over and help? We have right now 4 ambulances out, which is all the ambulances we had in the county, on real serious, type of, things." And I said, "You bet, Jeff, I'll be, right over." And in the matter of half an hour, our 7-bed emergency department there had 4 like level 1 type traumas and a variety of other, things going on. And so, like I say, the skills that you'll develop through, medical school and residency will, serve you well to, to be in positions like that, should you so choose. And like I say, it's just super rewarding because, not every day do you, go in and you have the, the big, save, or, you say, boy, I really, kind of saved that life that day. But there'll be, those days, and I've had plenty of them in the ER. I'll never forget the time that I was, working the emergency department there, and a guy was canoeing down the river and all of a sudden developed severe substernal chest pain. They brought him in, but it was like an hour transport in. He was diaphoretic, sweaty, his blood pressure was low, got an EKG, obvious heart attack, but we were 90 minutes from the closest cath lab. So we had a decision to make. This guy was critical and getting worse. And so, through consultation on the phone with the cardiologist, we decided to administer TNKase, that kind of clot buster that you sometimes give. And so we administered it to him, and kind of waited for the rhythm change that'll happen, and that happened. And all of a sudden his EKG just went back to normal. His blood pressure came up, stabilized. We were able to transport him you know, over to Springfield to be taken care of. And then, you know, you want to talk about quite a reunion when he came back and he stopped by the ER and thanked me. And that made, you know, that made it all worth it, is things like that. And that's the, you know, again, a beautiful thing that a family physician who's well-trained in a variety of stuff, you know, again, working in a rural area, you know, I mean, that's, you know, that's totally something that, you know, is out there and makes the job, you know, fantastic, and that, you know, makes me still passionate about it after, you know, I started medical school in 2000, graduated in 2004, and graduated residency in 2007. And so, and I'm still here kind of doing all the stuff, and I love it. And we just need more people to kind of be exposed to it and kind of understand that, you know, this is a practice that's totally doable, and get more people to do it, because our rural communities and areas and patients, they just really need, you know, that well-trained family physician. So that's kind of my story in a nutshell. And so I'd be interested to open it up to questions and see, you know, what kind of questions or what I can answer, if I can tell you anything else about my journey or the specialty of family medicine.
Thank you, Dr. Rasmussen. So what I would like now is for this to just be a conversation with him. So if you have questions or are interested, whether it's emergency medicine or family medicine in general, it sounds like he can answer probably almost any question you have. So
Right.
feel
Yeah.
free to join in.
So I do a variety of different things. Like I say, like this morning I was, I'm a director of one of the hospices down here. So we had a interdisciplinary team conference, and then I went over to the hospital and rounded. And then after I finish up this call, I'll head down to Harrison, Arkansas, and I'll cover a shift in the emergency department. And I'm over at my clinic now. I kind of checked in. I've got 2 nurse practitioners that kind of help me, you know, run things and juggle things, and it works, you know, really well. So that's kind of a snapshot in, you know, the day of the life of a family physician. So so please, you know, anything that I can help you with, or anything you have, you know, shoot them at me.
Any questions at all?
I was just curious for to do both FM and EM. Are you board certified in both, or did you have enough training in your residency to do both?
Good question, Noah. So I had enough training in my residency to do it. Now there are 1-year emergency fellowships across the country. There's a handful of them. One of them that stands out is at the University of Tennessee. And so I think kind of like with family medicine and obstetrics, like some people will come out of their residency and say, hey, I feel pretty good about, you know, my volume and what I've got. And then other people say, I'd really like to do like a 1-year fellowship. But as for me, you know, my journey is like, I purposely like set up like in medical school and residency a whole lot of like emergency type, you know, rotations, and kind of, you know, when I was on, you know, service, I'd sneak down to the OR and say, hey, can I intubate, you know, some patients before, you know, rounds or something like that. So I kind of sought out, you know, those skills that I would need. Another plug for like the American Academy of Family Physicians, they have a great emergency and urgent care course that they do annually that I went to as a resident, and man, that was really good. So doing different things, I think if you picked the right residency, you would totally be ready, you know, just through your 3 years in residency. If for some reason not, you know, there's those fellowships out there. But in order to be boarded now, like, unfortunately, I don't think you can just sit and take the boards. I'd love to actually do that, but I think you have to actually do like an EM residency. So I'm boarded in family medicine, and with kind of an interest in emergency medicine. Yeah. Does that answer your question? All right.
Yeah, absolutely. Thank you.
Yeah, sure.
I have
Anybody?
another question to kind of follow that up.
You bet.
Other than intubation, what are some other common procedures that you feel like are good practice for emergency medicine? Maybe like
Yeah, great question.
test tubes or anything like that?
You bet. So that'll come up, especially if you're working in a rural area, when you think about a lot of your critical procedures, why, those will come up, chest tubes will come up, like people get kicked by the bull, get, bucked off the horse and stuff. And so you'll end up putting in, a fair amount of chest tubes. And then other procedures would be, even with ultrasound. Now, the nurses are very facile with doing ultrasound guided peripheral veins, but still sometimes you may need a central venous catheter, or the nurses can't get it or whatever. So doing central lines is one of those. Occasionally, and this, you're not probably going to get into much emergent thoracentesis and paracentesis, but those are both skills that I have that come in very, very handy, especially when you're in a rural area and somebody comes in with a belly full of ascites, it's kind of causing some respiratory compromise. And the ability to do that procedure is fantastic and diagnostic and therapeutic. The other one that you think about is lumbar puncture. So you'll get those, cases, the febrile infant or adult, that you really need to do a lumbar puncture on. Or so those are kind of the main ones that, that I do. Of course, laceration repair, super common one. Joint reduction is the other, thing that happens a fair amount. Somebody comes in and their shoulder's out. And so doing some procedural sedation to get the shoulder back in place. Those are probably some of the more common ones that you need that, like I say, again, working, doing some rotations in emergency medicine when you're a resident and a student. And the other thing that's super nice is a couple of the shops that I work at are double covered. So you're not always just the lone physician, right? So, so sometimes, if you were to maybe think, well, I'd like to do emergency medicine, kind of seeking out those, shops that may have some double coverage. So you can kind of work side by side, especially it's great if you can work side by side with like maybe an emergency medicine trained colleague. So in our group, when we hire new emergency graduates or family medicine graduates, we'll usually try to put them on a double coverage shift for 6 months or a year, just to kind of get them up to speed, because that kind of stuff is so valuable. I mean, even where I am now, like it's super valuable. Just over the weekend, I was in Harrison, Arkansas. 14-month-old male came in, has a history of kind of reactive airway, trouble breathing. Mom was spraying like some sort of like bug killer or something in the apartment and just totally set off this kid's asthma. And initially it looked like, oh, no big deal. This kid, is sick. He's going to need hospitalization. But then just all of a sudden, boy, we went from breathing 60 times a minute to like 7 or 8 times a minute, like just kind of, he just was worn out. And so all of a sudden, now you're talking about having to intubate an asthmatic, which, ideally, if you can help it, you don't really want to do. But not only was it asthmatic, it was a little, 8 kilogram, 14-month-old. And so we were on a double covered shift at that time. And just having somebody there to kind of go over all the stuff and be there, it was super helpful, even after all these years that I've been doing it. So that's another, again, nice thing when you're thinking about, emergency medicine, and you gain those skills. So you have them. So when you're down in Clinton, Arkansas, and you're the only doc there for 24 hours and they don't have anesthesia and they don't have, anybody, you're kind of it. You'll have those skills that you need to kind of stabilize somebody and get them to a higher level of care. So good question.
So we have another question in the chat that from Morgan Murray about moonlighting. What's the best way to find opportunities, and did it make you more comfortable?
Oh, you bet. Yeah. So that's a good question. So So best, the best way to kind of find those opportunities would probably be to, through networking for sure. But, sometimes, just calling up the hospital and kind of checking with the medical director, because there's still plenty of places that need, some coverage, especially some of these smaller places. So when I was a resident in Springfield, that's how I initially got interested in Houston, was kind of through word of mouth. They were looking for somebody and they said, yes, they would, be interested in taking residents. And so, so kind of networking, kind of checking with some people that may know, and it totally, made me more comfortable. Now it's scary at first, because you really want to kind of have a phone your friend, close by if you can help it, because you go from, in medical school, you've always got, somebody that's right there, and even in residency, you've got a backup. But, sometimes, again, depending on, where you're moonlighting at, if you're moonlighting in a rural place that's single coverage, well, guess what? It's you, and so then all of a sudden you've got to, put your nickel down on the decisions, and you've got to kind of decide, which way they're going. And that's a little different than, what you've done before. You're generally running it by, somebody the whole time, but it puts you into it. It makes you make those decisions. And it's a tremendous learning curve, but it also really helps you. I mean, there's no doubt by having that experience that I was a much better, well-rounded, physician. But, but also, I mean, I won't be ashamed to say I also, wasn't shy in phoning a friend and talking to, other guys, or calling, Children's, hospital in St. Louis and saying, hey, I've got this or that, what do you think, and what do you recommend? But it's a great learning experience that again, I would highly recommend.
Thank you. Are there any other questions?
I have a quick question. Thank you for doing this lecture. It's been very helpful.
Sure.
Could you speak to what your experience has been in terms of job opportunities coming out of residency for physicians who are family medicine trained but want to do emergency medicine in non-rural areas?
Yes. Yeah. So I kind of stay in touch with a lot of, colleagues and different things. And I end up, for whatever reason, getting called by, a number of recruiters for this or that, to say, hey, are you interested in a job change? And I can tell you that there is no lack of, jobs for the family physician who does emergency medicine. Now, a lot of those, jobs may be in some, kind of moderate volume or lower volume, emergency departments, just kind of due to some politics and different things. Like, it's a little harder for a family physician to work at like a big level 1 trauma center, but there are plenty of jobs out there. And the funny thing is, when I talk to my emergency medicine colleagues, my partners, they say, these jobs that we work in, like the community hospitals and the single coverage, hospitals, are actually harder to do than what it is to work at a level 1 trauma center, where you can just pick up the phone and anesthesia's in house and they can come right down. Cardiology's there and they'll come right down. And so, but you won't have any problem, now or in the future, if you choose to do an emergency path, whether, part-time or full-time, like, those jobs are out there. And the other nice thing about, kind of choosing to do emergency medicine, again, part-time or full-time, is it generally pays, significantly better than, maybe just outpatient or office-based practice. And so that's another, nice perk. Now, the downside to that, of course, is the emergency department is open 24/7, nights, weekends, holidays. And so, so you have to be prepared to kind of, work some shifts on, on those type of things. In our partnership, what we do is we rotate holidays. Like, if I worked Thanksgiving last year, then I'll get Thanksgiving off next year. And, you know, we have like a block, so I might not actually have to work on Thanksgiving, but I might have to work like that 4-day block. But then the next year I'll have that off and I'll have to work like a Christmas block or something like that. So. Does that answer your question okay? Does that
Okay.
answer- Yeah, okay, perfect.
So I want to be respectful of your time, and our 30 minutes is up, but I do want to point out that these sessions are sponsored by the American Board of Family Medicine and the Missouri Health Professional Placement Services Program. So if you're looking for loan repayment assistance and job placement, they are the location that you can find that information. They are hyperlinked from our webpage with the day in the life information on it. Our next session is scheduled for April 28th, and Dr. Kurt Gravata from Citizens Memorial Health Center in Bolivar is going to talk to us about his subspecialty in addictions medicine, and he will be awesome to listen to. He serves on the MAFP board, and this is a passion of his. So we would hope that you'd be able to join us for that session as well. Thank you, Dr. Rasmussen. We appreciate your time
Thank you.
and your insight and helping our students find their way, hopefully, to family medicine.
Yes, my pleasure. And Kathy, would you mind sending out my email just in case there were any follow-up, questions, or if I could help anybody in any way? I love to take students and I love to help further education in family medicine. And so please, send me an email or, look me up and come rotate with me sometime, and I'll kind of show you my world.
That sounds great. I will be sending out an email with a link to the recording. So when I do that, I will include your email address with it.
Yeah, great. Thanks so much,
Awesome.
everybody.
Thank you very much. You all have a wonderful day.
Bye-bye.
Bye.